What I'm going to be doing with you in the next hour is talking to you about what health reform means, where hospitals and physicians can find common bonds in the new environment seen through the perspective of physicians. I'm going to elucidate for you my understanding of what makes physicians different that is really important to advancing quality and improving value. I'm going to talk about some non-acquisition, non-employment financial strategies that can go on between hospitals and physicians to advance quality and value. I'm going to introduce you to the only really new payment model that's on the horizon, and then I'm going to talk a little bit about clinical integration and why that is the key to your future. I am hoping to be a little provocative, not in the sense of being obnoxious, but in the sense of provoking you so that you actually think about your futures in a somewhat different way. So let's get started. Okay, this slide is an interesting slide. People look at it and go, what is that? I've probably read every piece of federal health legislation since the summer between my second and third year of law school, which was not last week. That would be 1972, when the first Medicare amendments, big Medicare amendments, had been passed after Medicare had been enacted in 1966. And when I read the health reform legislation, not the 1,000 pages that have to do with what everybody is fighting about in the courts, which is about the individual mandate. I think that's a good thing. I think people can fight about it as much as they want. It doesn't really interest me. I live on the provider side of the street. I primarily live with the physicians, and there's 1,000 pages in this legislation that's about the provider side of the street that nobody is arguing about. And I was so struck by the change in the language in that 1,000 pages of the legislation that you can actually do this now with Adobe Acrobat. I counted by punching search each time these words appeared because they meant such a shift in the idea of what healthcare is supposed to be in this country. So I counted that the words efficient or efficiency appear 89 times, value or value-based appear 115 times, effective, that's effective medical care, effective or effectiveness appears 146 times, and the real showstopper was that the word quality appears in this legislation more than 480 times, either as high quality, quality improvement, quality reporting, quality measures, quality data, quality of care, or quality performance. This is a very different environment that is being posited in terms of the delivery of healthcare in this country at all levels. The hospitals who are your significant others, and increasingly will be so even how many primary care guys who don't go to the hospital anymore? Hospitals still going to be important to you, and I'm going to explain why. The first is the hospitals are standing on a burning platform. The money that they have had available to them, with which they are paying these inflated salaries of employed physicians that I'll come back to in a few minutes, are looking at a value-based hospital purchasing modifier for which we already have final regulations. What is happening is that every Medicare hospital is having their DRG payments slashed by 1% this year, next year by 0.5%, the following year another 0.5%, and so on for the next 5 years. The money that the hospitals are not going to be paid is being reserved in a pool that will be available to pay more money on the DRG to those hospitals that score well on measures of at least 5 conditions in terms of their quality performance. The measures that will be chosen, and the first ones that have been chosen, have to have already been reported by hospitals for at least a year on Hospital Compare, which was that formerly voluntary quality reporting thing that now you lose money as a hospital if you don't report data, so 98% of hospitals report their data properly. In 2014, hospitals will also be measured not just on their quality, but on their efficiency. Read that as low cost. And the differential payments will be made to the higher value organizations, which are those that have higher quality and lower cost by comparison with others. All of the data that is submitted, as in all of the programs of measurement in the legislation, will be posted on publicly transparent internet websites. Probably unbeknownst to many of you in the room, these hospital quality and efficiency measures are to be coordinated with physician quality and physician measures. More about that in a moment. In addition to the value-based purchasing reductions, hospitals are looking at reductions in payment for hospital-acquired conditions. Do physicians contribute to the creation of hospital-acquired conditions? Yes, they can. If you have surgeons that are still shaving surgical wound sites instead of clipping, the risk of higher surgical wound infection rates go up, and absolutely physicians can contribute to that. Are they the cause of hospital-acquired conditions? No. But if they aren't on board with attempts to prevent hospital-acquired conditions, hospitals will not succeed on that financial front either, where there will be reductions in payment. There will also be reduced payment for hospital readmissions within 30 days. Who's writing the orders for those readmissions? That would not be some case manager or you, our nurse. That would be a physician. Very often now, a physician in the community who no longer attends in the hospital because the hospital has a hospitalist program. So hospitals are going to be very eager to work with community-based physicians to truly create a safety net that will keep patients out of the hospital when readmissions can be prevented. So for physicians specifically, there was no real payment reform, as you're all aware. There was some increase in primary care payments for a relatively brief period of time. There will be, beginning in 2012, for those of you who are following the fantasy that Medicare physician fee-for-service is going away, that would be wrong. In 2012, you will be measured and will be scored on achieving composite measures of quality reflecting outcomes which are risk-adjusted and National Quality Forum endorsed. What does that mean? Scoring well on composite measures means it's not enough that you counseled on smoking cessation or you did a diabetic retinopathy exam. It means that smoking cessation, diabetic retinopathy exam, good HDLs, good LDLs, good blood pressure, good hemoglobin A1C, all 6 of them you have to score on in order to get credit. It's much harder than the one-by-one pay-for-performance kinds of things that have existed up until now. Similar to the hospital environment, after 2 years of being measured and reported on with differential payment on quality, efficiency measures will be added. Now, many people go, how are we going to be measured on efficiency? There's nothing in existence that will do that. How many people in this room know what an episode grouper is? Thank you. Those are all the guys who are working on socioeconomic stuff. Episode groupers are these secret black box, typically proprietary software packages that virtually every managed care plan with which you contract has been using to internally array of physicians in measuring whether they are high value or low value, meaning that they are high cost, poor quality, or low cost, high quality. The 2 primary versions of this are owned by Thomson Reuters, that owns all media that Rupert Murdoch does not own. And they own a company called MedStat that created medical episode groupers. And then there's the other Borg, which is United, and they have something else that they own called Ingenix that just changed its name to Optum. I don't know what that was supposed to help, but they own something called episode treatment groups. The black box algorithms are secret. No one knows what it is that they're doing by way of the analysis. And there have been battles over this. Many of you may remember in St. Louis, there was a big fight between Ingenix and physicians who were excluded from networks on the basis of these software packages. And in New York, Andy Cuomo, when he was the Attorney General, went after Cigna, and they entered into a settlement that affected some of the other managed care organizations that are engaged in this. Well, what Congress did in the legislation is they said enough of this. The Rand Corporation had done a study that basically said these forms of black box proprietary algorithmic analysis of claims data are, the technical term would be garbage. They have just as much likelihood of saying that a good guy is a bad guy and a bad guy is a good guy as the obverse. So in the legislation, there is a call for the secretary to contract with one single company that will do a publicly transparent episode grouper where you will know what you're going to be measured on, the measures will be made available, and the methodology will be made available. 4 people bid on this contract, 4 organizations: Thomson Reuters, MedStat, 3M, which is in this business primarily on the Medicare side, and then another consortium that's a not-for-profit consortium that consists of Brandeis, the American Board of Medical Specialties, the AMA's Performance Improvement Consortium, and the Healthcare Incentive Improvement Institute, which is a not-for-profit that I am the chairman of the board of. A little bit more about that later. The work on the initial statement as to how the episode grouper would be implemented was submitted 2 weeks ago, and before the end of the year, the secretary will announce which one of these 4 organizations is going to get the contract to do this. The legislation also calls for a bundled payment pilot, which is different from what the Center for Medicare and Medicaid Innovation has just published, which is the best thing they've done as far as I'm concerned, which is a call for providers to come forward around 4 different models to propose how they would do bundled payment. 'Cause let's be real clear about this. Nobody really knows anything about bundled payment. Medicare had their ACE bundled payment pilot that took place in the Southwest, worked pretty well. People saved some money and improved the cost profile, but we really know very little about all of that. So that's the environment in which hospitals and physicians will find common cause, but physicians on their own behalf ought to be thinking about how they're going to be measured, they're going to be tracked, they're going to be evaluated. It's going to make a difference in how you get paid on your value performance, which is improved quality with lower or at least even costs. So let's look at some other common bonds that exist between physicians and their hospital significant others. And I spend a lot of time talking at hospital board retreats and hospital administration and medical staff retreats about this idea of why one should focus on physician engagement around quality in the hospital environment. And I will tell you flat out that I am a physician exceptionalist. I believe that physicians are different from everybody else in the system, and I'm going to tell you why they are different. And this is not some delusional notion around the arrogance of physicians. It is a true statement around what it is that physicians do that no one else in the healthcare system does. The first reason that physicians are so central to what goes on in hospitals is they have what is called plenary legal authority. It means they have the broadest scope of legal authority of anybody in the healthcare system. They perform the most critical and intimate procedures that patients will experience. Everyone used to say that the most expensive form of technology ever invented in American healthcare was the ballpoint pen with which physicians write their orders, but now the mouse click is equally as important. Virtually everything that happens in a hospital is ultimately derivative of a physician order. Now, you can't have a hospital without nurses. There's no such thing as a hospital that does not have nurses. But nurses are not doing the same thing that doctors are doing. They are doing different things. In addition, physicians experience the healthcare system through their relationship with a physician. Physicians are the portal to the healthcare system for patients, which is why when the new healthcare plan comes to town, the first question that anybody asks is my doctor in the network? I love healthcare advertising. I travel all around the country and sit alone in hotel rooms laughing out loud. In my local market, we have a health system, the Temple University Health System, which is the remainder of the war on poverty. They're in a terrible neighborhood. They used to have a really fabulous heart transplant program until the transplant surgeon left. Now their heart transplant program, not so much. But when they had this fabulous transplant program, they would have advertisements on television, and they were testimonial advertisements. And one of the guys who gave testimony in these testimonial advertisements was a client of mine. He was an ophthalmologist who'd gotten a heart transplant. His name was Dr. Aranon Sivalingam. And there was Aranon on television going, I got a fabulous heart at Temple. I love these ads. What am I supposed to do? Wake up the next morning and say, oh, I think I'll go get me a new heart at Temple? People go where their doctors send them and what's covered in the network on their managed care plan, unless they have some very exotic cancer, in which case they want to go out of network to some center of excellence that their plan will fight them about going to. So the real issue is that physicians, because of the unique role that they play that I've just described, can enhance the results in hospitals, can improve the culture in the organization, and foster truly effective interdisciplinary collaboration, which is what your future is going to look like. But their disengagement can thwart almost anything that goes on in a hospital. How many of you know the story of the Cedar Sinai implementation of computerized physician order entry? I love this story. It lets me use a phrase that you don't get to use very often. They introduced CPOE in Cedar Sinai on a hospital-wide basis, and the next day the medical staff, here's the phrase, rose as one and refused to use the system. What medical staff has ever done anything as one? They described it as cumbersome, dangerous, and unwieldy. Now that's a failed physician engagement story. I'm pretty sure the battle really wasn't about the CPOE. Knowing what I know about physicians, this was some bank shot passive-aggressive thing that had to do with some other battle that was going on in some other place. But whatever it was, Cedar Sinai thought they were engaged with physicians, but they apparently didn't do it very effectively. But I haven't really elucidated for you, for quality and value improvement purposes, what really is the transaction that goes on between doctors and patients that you all should be thinking about as you position yourselves in the next environment. The most elegant statement I have ever read or heard that describes the uniqueness of what it is physicians do is written by my friend Jim Reinertson, who's a rheumatologist, who said the following thing: physicians transform information into meaningful explanations of the present, predictions of the future, and changed futures, mainly for individual patients and sometimes for whole populations. That's kind of profound. Jordy Cohen, who was then the head of the American Association of Medical Colleges, picked up this statement and recharacterized it in the following way. The fundamental nature of the transaction that takes place between physician and patient, as complex, multifaceted, and enigmatic as it is, can be captured in just 3 questions that people seek answers to when they are sick. People basically look to their physicians to, number 1, explain nature, what is happening to me? 2, predict nature's future, what is going to happen to me? And 3, alter nature's future for the better, what can be done to improve what happens to me? As Reinertson says, we take information on this hard drive about health and transform it to a higher order of information, not just as an intellectual exercise, but to satisfy the 3 fundamental needs of explanation, prediction, and change. We can do other things in the course of our day, but all are secondary to this primary task. So the Institute of Medicine picked up on this in their study Crossing the Quality Chasm, and if you read it, it's a very important study, actually, a little turgid, but worth reading even a few years since it's been published. The statement is made in that study, the transfer of knowledge is care. The transfer of science from this hard drive to an individual patient is care. Whether that transfer occurs through dialogue, through writing a script, through performing a procedure, through interpreting an image, it's a transfer of what's on this hard drive to an individual who presents with socioeconomic factors, genomic issues, allergies, what they want and they don't want, preferences. So what we now know is that high quality care is care where that individualized transfer of knowledge is optimized. The idea is to standardize to the science as much as possible so you can custom craft that unique transfer of knowledge to the patient that's sitting in front of you. What does this mean for quality and patient safety and value initiatives? There are 2 things that physicians need more than anything else to optimize this transfer, and those 2 things are time and touch with their patients, which means that when you guys are thinking about where you want to be spending your energies around changing the way you practice medicine, which you are going to have to do no matter what going forward, the touchstone of ruthlessly eliminating from your environment those administrative and clinical processes that steal time and touch from patients is not just a quality of life issue, it is a true quality of care issue. Unless you have time to hear that patient's last lingering, oh, but say, doc, I really meant to ask you about this, which was the true reason for the visit and not what they said when they made the appointment, you won't be able to function in the full capacity of what being a doctor is about. So now let's look at physicians and health systems. I have long said, working for many years on the issue around engaging with physicians, health systems will not succeed without the enthusiastic engagement of their physicians. Whether they are bought or employed has exactly nothing to do with the potential for success in that realm. Because what I'm talking about, that health systems need to have at the forefront of what they demonstrate to the American public is a connection with physicians if they are going to be held accountable, because it's about what the unique values of physicians are, and more on that in a few minutes. So is there any evidence to support this bold statement that I've been making since at least 1998 when I wrote a paper for the AMA called Quality and Clinical Culture, the Critical Role of Physicians in Accountable Healthcare Organizations? Let me go on the record, I used the term before Elliot Fisher even knew of it. And you could look it up. The paper's still on the AMA website. But I was privileged to attend a meeting that took place a year ago, September, that was called by Bassett Healthcare, the Commonwealth Fund, and Academy Health when it looked like, I guess it was September before that, when it looked like health reform was going to be imminent. And there had been a paper, there'd been an article published in the New York Times about Bassett Healthcare, which is one of the old line American Medical Group Association groups in Cooperstown, New York. It's the model of many of these organizations like Mayo and Park Nicollet and Scott and White. They were started by doctors, and they basically take over the hospitals which they were affiliated. So the hospitals are really just another service line within a large integrated physician group. And Bassett was one of those models, and there was an article about how they were a high-performing, high-value health system. But one of the issues was that most of these organizations employ their physicians. They use the group employed model, GEM. And so this meeting was a meeting of GEMS organizations, group employed model organizations. And the idea was that they were going to talk about what they could elucidate as distinguishing their activities from the mediocre middle of American healthcare that could be replicated in environments where physicians are not going to be employed. Because it took 100 years to build the Mayo Clinic. It's not going to happen with a bunch of mergers and acquisitions lawyers writing boxes and arrows on a page. This time of transformational change any more than the last time of what was not so transformational change in 1995. And I will tell you that in this meeting, there were only 3 non-physicians in the room. I was one of them. I'm not even sure why I was there at the meeting, but it was an interesting meeting. After lunch, the facilitator said to the 34 other people who were in the room representing these organizations, we want you to write down on a piece of paper those 2 things that you think distinguish your organization from the mediocre middle of American healthcare that is really important for organizations that want to move forward in a high-value, high-performance frame of reference. And they all dutifully wrote something down. And then they went around the room and they read their papers. And it wasn't like one guy said something and then the next guy said, yeah, I would agree with that. Every one of them read from their papers. And every single person in the room, to a person, said something like, we are physician-driven, we are physician-led, ours is a physician culture, the doctors are the leaders. That's not about a power grab. That doesn't mean that these organizations don't have CIOs and they don't have CFOs. They do. They have all of the C-suite financial armamentarium that any of these organizations would have. What this statement is about is physician values deeply embedded in these organizations and driving their culture. Here's some other statements that emerged from that study that I think are important. I don't know where this clicker aims. There we go. Physician leadership is critical in developing 2 characteristics which are critical to supporting their ethos: collaboration, and I'll come back to that in a minute, and accountability. Integration with hospitals is important as it instills accountability and promotes the coordination of care across inpatient and outpatient settings. Engaging physicians in governance and operations is important. There's more in this study that I would commend to you to think about. What is it about those organizations that we could replicate in our environment that would drive us towards high performance and high value? But if you're going to do anything with physicians, it's really important to understand not what they do that's different, but what they are that's different. How many non-physicians in the room? This slide is the most important slide I'm going to show you. I've never seen any of this written anywhere. I've been talking about it for years. If you're sitting next to a physician and you're a non-physician, you're going to see the response that these observations generate. The first thing that physicians do and are that is different from everyone else is they take responsibility for individual patients. They treat their patients one by one by one. You can talk about populations, you can talk about patterns of care delivery. Physicians treat the patient in the chair, the patient on the table, the patient in the room, the patient whose image or slide they're looking at, one by one by one. The second one I've never seen talked about anywhere. This is something that physicians never discuss, but it's profoundly important, particularly for patient safety and also for improving quality. Every single physician has felt at some point in his or her life, no matter how far from training, a daunting, searing, life-changing accountability for life and death. What I mean when I say that is that every single physician you will ever meet, no matter how far from training, will be able to tell you forever the name of every patient they think they killed or harmed on the basis of an honest mistake based on imperfect information made on the fly under imperfect circumstances. And so what I say to non-physicians is if you knew that you were at risk for this terrible thing happening again, for which you feel accountable, what would you do? You would pull up your socks and you would put on your armor and you would gird your loins for the battle of the day. God forbid this should ever happen again. And the major way that physicians prevent this, and they don't even talk about it with each other, from ever happening again is by trying to control everything in their environment out of a personal sense of responsibility for this accountable thing that has happened. This is something that we need to help physicians change. In environments that are oriented around systems that safeguard patient safety, these kinds of problems get mitigated. And as a result, some of what non-physicians perceive as arrogance is exactly precisely the opposite. It is that struggling to prevent that green pit of goo in the bottom of my stomach at 3 o'clock in the morning when I know I made a mistake. And maybe I didn't kill somebody, but I know I made a mistake, because physicians make mistakes, even those who are at the peak of their careers. This is a really, really important thing for physicians to talk to each other about. The third is physicians overestimate the risk of being sued in malpractice by threefold. There are studies that have demonstrated this. They believe they are the legal captain of the ship because the law tells them that they're the legal captain of the ship. The plaintiff's personal injury lawyer is going to go after the doctor first and everybody else second, and they will tell that to you. It was not even until 1974 that there was even a case law that said that a hospital could be held liable for the actions of a physician that it had chosen and allowed on its medical staff or put into its emergency department. So what does this mean if you're moving on initiatives around quality and value and patient safety? It means that you better have a story to tell about what this is going to do to the physician's malpractice risk exposure. And the story better be this is going to improve your exposure profile rather than heighten your exposure profile. Most things that you do around quality will lower malpractice risk. Incidentally, two things are shown to lower malpractice risk. The single best risk management technique that exists, bar none, is a good doctor-patient relationship. That's been shown in studies for the last 35 years. Patients don't sue the doctors whom they love. A good doctor-patient relationship is the most critical bulwark against malpractice liability you could ever have. The other thing that's interesting is there are now studies that show that physicians who do not explicitly follow clinical practice guidelines have a 6-fold increased risk of being sued. I didn't say of a bad event. I said of being sued. So standardizing to the evidence base is something you also want to think about as a malpractice prevention thing. The fourth bullet point I didn't have on my slides when I first started doing this slide that comes out of my 1998 AMA paper. And all around the country, individual physicians would come up to me and say, yeah, but what about collegiality? Now, this is a word I had heard my entire life, because my father was always very fond of saying, medicine is a collegial profession. And then when we all became lawyers, he has 2 children who are lawyers, one's a doctor, but he's got 2 grandsons that are lawyers, so he's sort of surrounded by all of it, and he refers to us uniformly as you damn lawyers. So he said, Medicine is a collegial profession, not like you damn lawyers in an adversarial profession. I used to go, well, what is that all about? Maybe it's just a big band of brothers thing. We're all in it together, nobody understands us. There's a little bit of that, but for quality purposes, the real issue is that physicians are trained in a way that the rest of us professionals are not. You are trained to share your intellectual capital with your colleagues. When a physician calls a consult, first, he's admitting he doesn't know everything about that, which is kind of interesting if you think about it. Okay, I need help. I need a specialist of a different kind to come in and tell me what to do about this particular thing. And then the specialist comes in and says, okay, I'm going to share my intellectual capital with you for the benefit of this patient. It's a very different style of professional interaction, certainly than lawyers who steal clients from each other and each other's lunch. Now the fourth bullet, and this is also something useful in quality and value improvement exercises, because it means you guys have a reason to like to work with each other. You like to interact in grand rounds that are meaningful. You like the intellectual challenge of relating to each other. That's something that you need to draw on more. Physicians come from a science-based background. They're trained in science. A's in organic chemistry. I made sure there was no math requirement in any college I applied to. Which is true for many lawyers. But, and I like this quotation that Reinertsen uses to describe the science basis of medicine, because I get to use a word that I don't get to use very often. He says, I think the distinction between the practitioners of so-called alternative medicine, chiropractors, homeopaths, naturopaths, and others, and those of us who claim our grounding in science, is that the alternative practitioners are often very skilled at meeting the first two needs, explanation and prognosis, but they don't often actually change the future for their patients, at least not for those with meningitis or insulin-dependent diabetes or comminuted, that's the word, fractures of the tibia and fibula or infarction of 2 feet of their small bowel. For this is the real miracle that science brought to medicine. To truly alter the future, the doctor must have an effective craft, one worth knowing, not just a sham, and must use that craft with wisdom. I think that's really cool. When I was 5 years out of law school, I had this sort of period that I used to refer to as the fever, where I thought I wanted to go to medical school. Thank God my husband was smart enough to say to me, who's going to pay for that? Because all our money is going to the next generation. And I didn't want to actually be a doctor. I just wanted to know all that stuff, because I think it's really interesting stuff. Anyway, so you guys come from a science base. Remember that when you're working on quality and value and what's to be improved. I want to skip down to the due process as the scientific method. Whenever I work on medical staff bylaws, when we get to the section on the fair hearing stuff, the doctors who are on the committee all go like this, oh my God, it's that awful lawyer stuff. Do we really have to do this? And I go, yeah, you're going to know why every word in this is written the way it is when we come out on the other end. Because what's the first thing any doctor says when either his ox gets gored or his buddy is being harmed in some way under the medical staff bylaws? Where's his due process? And I used to think that they all sort of go to a different 7th grade civics class and bond with the Constitution in a different way than I did. I mean, I'm an actual lawyer and I don't feel that way. So I thought about why this was, and I finally figured it out. I think the reason that physicians are so bonded to the idea of due process is that it's like the scientific method. In the scientific method, you have a hypothesis. You test the hypothesis in the crucible of experimentation repetitively. You record your data. You go back and you look at the data again and you analyze the data. Was my hypothesis good or was my hypothesis not good? When you have somebody whose privileges are going to get jerked because he's not working effectively or he shouldn't be performing those procedures, physicians think it's better if you have a hypothesis. His privileges should be pulled. Let's examine it in the crucible of cross-examination. We'll look at the records. We'll ask people what they saw. We'll ask them questions. We'll see what the data shows. We'll go back and we'll reevaluate the data, and then we'll have a better, more equitable decision than if we had just sort of made a wild-ass guess to figure out what to do next. So what's the message in terms of quality-oriented, value-oriented activities? It's that if you're going to do something that has the potential to exclude someone from a network or say you don't get to play in our little pile, you better have a story about due process. Doesn't mean everybody gets a jury trial for every infraction. Actually, what physicians don't know is that the Constitution requires the process that is due under the circumstances. I've worked with medical staffs that offer a full fair hearing for a letter of admonition. Let me tell you, nothing ever happens of a quality control nature of a peer review nature, of a peer control nature in that kind of a setting, because everyone's too daunted by the system. Okay, let's move on to some non-acquisition things. I'm not big on the new version of hospital employment of physicians. I think it's motivated by all the wrong stuff. I think there are too many specialists who are deluded into thinking that they're going to be employed by the hospital and go merrily on their way doing precisely what they've always done. They believe they have financial security. This is completely a delusion. If you look at the value-based purchasing stuff and the burning platform, and keep in mind that in a quality-driven environment, hospitals are going to see far fewer of the kinds of admissions they see now. When chronic care works better and people aren't readmitted for CHF, they lose those readmissions. When diabetic care is better, they're not going to see as many admissions, primary diagnosis diabetes or diabetic stroke or amputations or eye procedures. So in a real quality-driven environment, hospitals are going to be seeing about 30% fewer of the kinds of admissions that they see now. Where is the money going to come from to pay for all of these agreements? I've even worked on them that have 10-year terms that are promising physicians even more than they're making today. It's not going to be there, so there's no financial security. And my contract is my protection. Clients say to me, can you write me an ironclad contract? Oh, I say, I can write you a brilliant contract. That has nothing to do with whether anybody's going to abide by it or not. And if they don't have the money and they're going to say, we're not going to pay you, then pretty much that's what they're going to say to you. And you're going to have to figure out whether you want to spend the next 5 years in a lawsuit with them, which is entirely counterproductive. The hospitals are taking these people on also out of delusions. The first is if we pay them on a W-2, we can control them. Ha! The second is, this is going to give us a really big footprint, which means we'll be able to bargain better with those nasty payers. If the hospitals aren't orienting themselves around value, they're not going to succeed in the coming environment either. And you've seen that Medicare is going to ratchet down what they pay to the guys who aren't doing well, and I guarantee you the commercials are going to do the same. There's a paper that I've given you a link to called Informed Consent to the Ties of the Mind that Reinertson and I wrote together. We sent it to the Journal of the American College of Physician Executives, and it's a pretty edgy piece. It basically says, we bet your consultants are telling you this. They're full of crap. Here's the right answers to the questions that you should be asking about this. And we sort of thought that when we sent it in that they would say it was, oh, this is a little edgy for us. And they printed it without changing a comma. So it's a kind of an entertaining read, but it also has some important stuff in it. Now that the new final ACO regs just came out, I would recommend again that if you haven't seen it, go to YouTube and type in, I want to be an ACO. And have you seen this video? It's absolutely hysterical. This is like a documentary movie of CEOs all around the country. It's one of those extra normal cartoons. Watch it. All right, so what are some things that I've been working on that actually are not about being employed or acquired? The first is I have a number of groups all around the country who are leasing their practice to the hospital. That means they stay as a group, they reassign the right to payment to the hospital bills for them, and they get paid a guaranteed amount of money predicated on a certain volume of work RVUs. Not an uncommon way to go, and the hospital takes the risk on the billing. Incidentally, on the employment side of the street, most physicians don't recognize when they go for these employment relationships that the common law definition of employment is a master-servant relationship. So in one of these leasing the practice transactions, I was representing a big cardiology group, and the in-house counsel at the hospital, I've done a lot of things on the other side of, she said to me, is employment off the table? I said, let me tell you how much employment is off the table. I said, my guys don't want a master-servant relationship with you. They want a you can never replace 22 cardiologists at once relationship with you. And that's what leasing the practice does. Many of you may be looking at co-management agreements. That's where the hospital says to, it's usually cardiology, orthopedic, sometimes oncology, sometimes cardiovascular. They say we want to be really engaged with our physicians who will be involved on a far more day-to-day basis on the hospital side of the street, helping us do the clinical management of what this service line is about. And in those co-management deals, whether there is an entity that the physicians buy into that then contracts with the hospital, or whether it's just done by contract, usually what you get paid for is improved quality performance, which now has dollar values that can be associated with it because of the new payment models and the new Medicare rules around how we pay on quality. Remember my business about time and touch is the thing that physicians need most in their lives? It does not help you to be paid $250 an hour to go be a medical director for the hospital, because all you're doing is swapping 1 hour of time in one place for an hour of time someplace else. What you want to get paid for, and I have had groups who've said to me, what do we do when the hospital says to us, we only want to employ you? I said, well, the best analogy I can give you is that I have a friend who's a recovered alcoholic, and I had another person that I knew who I thought was abusing substances and drugs. And I said to my friend, the recovered alcoholic, does it help to tell somebody over and over again, you really shouldn't do that, when they don't seem to be listening? And she said, yes. I said, why? She said, you never know when they're ready to listen. So these physicians who say to me, what do we say to the hospital that says we only want to employ you? I said, you approach them as if they are approaching the recovery of alcoholism. And when they say we want to employ you, you say, thank you, I don't want to be employed. I would like to help you improve your quality results and be paid some fair market value quantum that third parties create for the improved quality that we are helping you achieve by virtue of our efforts with you. Physicians even today can be paid flat out by hospitals for improving their quality results. It's a little bit complicated to do, but Stark even recognizes that. You can be paid for personal services. Most medical directorships that I see now have quality performance bonuses associated with them. All of the service, and I know in Texas there are some hospitals that are already paying for any medical staff service, but the medical staff does not exist to serve the physicians. The medical staff exists to advise the board of the hospital on the quality of care in the organization. So everything that physicians do on the medical staff can be compensated by hospitals without any problems under Stark or anything else. The second bullet point I haven't seen so much in this go around, but in communities where there are multiple hospitals that are employing physicians, you can be paid for a right of first refusal to stay independent. And what that means is that it's written like a real right of first refusal, that a hospital pays you money to stay independent. It doesn't require your referrals or anything else. But if you get a bona fide offer that you're planning on accepting, you have to let them take the first shot at employing you if you were going to go take employment with somebody else. Hospitals are buying administrative services from some of my clients who are doing the leasing of their practices. The hospitals don't know how to bill for physicians. They screw it up endlessly. My guys are much better at billing on the Part B side of the street. So they were already doing the billing for some of the hospital-employed physicians, and now they have the contract to do all of the billing for themselves. And hospitals are increasingly, for the community-based physicians, selling them the time of nurse practitioners and PAs. You can lease on an hourly basis an NP or a PA as a primary care physician, and when they reassign the right to payment to you, you can bill them at 85% of the Medicare physician fee schedule and get paid for anything that a physician would get paid to do, as long as it's within the scope of their practice. It's a phenomenal moneymaker for primary care guys that can't afford to hire these people on their own. A little bit about payment. Everybody's talking about new payment models. Actually, not so much. The medical home, we know a lot about medical home, the clinical movie, which is about keeping patients out of the hospital and avoiding complications out of the hospital. But we don't know very much about medical home, the payment movie. No one knows how much to pay medical home physicians. In southeastern Pennsylvania, there was a collaborative that got created at the insistence of the then Democratic governor, and he forced the two big payers in the community, Independence Blue Cross and Aetna, to the table to pay a little consortium of primary care physicians in a 5-county area to develop themselves into patient-centered medical homes. They basically got paid about $44,000 a doc to do this. Interestingly, that's about how much it costs to implement an EHR for a physician, but there was much more going on than just the EHR in this patient-centered medical home. But the notion that physicians should be paid for coordinating the care of patients, or should be paid when they're not yet coordinating the care of patients so that they can, has been described to me by Ann Weiss, who's a project officer at the Robert Wood Johnson Foundation, as if only. I said, what does that mean? She said, you know, medical home, if only. It's like, if only I were 5 inches taller, I would feel a lot better. If only I lost 10 pounds, I would look better in my bathing suit. If only my husband worked out more, I would love him more. If only you paid me to have a better infrastructure, my quality would magically improve. So there's a big dilemma as to whether we give physicians money in order to create medical homes, or we give money to physicians who have created medical homes. The second thing is getting a whole lot of play in the industry, and it seems sort of silly when you hear it described the way I'm going to describe it. Geisinger, which is in Pennsylvania, is a health plan, a hospital. It's a totally integrated system. Geisinger came up with this idea that they call proven care, and they started with cabbage, where they said, if you have a cabbage and we do it on you and you, in essence, spring a leak, we won't charge you for the rework. Why is this revolutionary in healthcare? If you buy a car and the 4 tires go flat when you're driving it down the street after you took it out of the showroom, you don't pay for that. Why in healthcare do we pay for rework and things that have gone wrong and stuff that could have been prevented? So basically what Geisinger said is, we're giving you a warranty. We'll say that if we did it, we'll stand good for it. Okay, well, that's not a bad thing. It's a good thing, but it's not going to get us anywhere to real transformational change in healthcare. Here's something that will help a lot. In the interest of full disclosure, I am one of the original members of the design team that created this. I'm the chairman of the board of the organization that stewards it. How many of you have heard of Prometheus payment before? Sadly, not enough hands, but at least a few. The name is an acronym. It says what the program is. Provider payment reform for outcomes, margins, evidence, transparency, hassle reduction, for the physicians particularly, excellence, understandability, and sustainability. People go, who came up with that? I did. We didn't have a name for this thing, and we'd been working on it for 6 months, completely pro bono. It's a 501c3. I've worked on this stuff for 6.5 years. No one's ever paid me a penny for it, nor anybody else who was in the original design team. And I thought, well, we need a name. Maybe it should be something mythological. So I went to a website that had mythological names, and I said, oh, Prometheus, that's a good story. You know, he stole fire from the gods and was the father of civilization because he gave fire to mankind. And I thought, oh, wait a minute. I've seen the painting at the Art Museum, because it's in the Philadelphia Art Museum. There's that business about the eagle pecking out his liver every day. Maybe I need to read this story. Maybe it's not such a good story. So I went online and I read the myth in like 18 different versions. And people never read it all the way through. It's true. Zeus condemned him to be changed to a rock for 30,000 years because he committed the sin of hubris by stealing fire from the gods. But after 30 years, he relented. And he said, it's not such a bad thing. Let him off the rock. We've already done our 30 years. So the Prometheus thing, it's just fine. So I'm not going to belabor this slide. I'm just going to tell you it's a 501c3. We have pilot sites all over the country. What is the basic idea? The idea is, here's something revolutionary. Wouldn't it be remarkable if we paid physicians to deliver what science says a patient needs from their condition? So the first thing that distinguishes Prometheus payment from everything else is that we start with clinical practice guidelines, not that we write, that already exist. And we have working physicians, practicing physicians, look at the guidelines, analyze them, and say, to deliver what this guideline says, you would have to do this list of services. So it comes from guidelines, and a budget is created out of claims data, and I'll show you a little bit about how that works in a minute, that establishes a budget for every provider, hospital, physicians, pharma, clinical lab, rehab, skilled nursing facility. There's a budget for all the providers who touch the patient that's established to treat the patient for that condition. We call them evidence-informed case rates, and groups come in. It works for onesie, twosie physician, big integrated delivery system, PHO, IPA. Again, we don't care. You come forward and say, measure us this way. Where does the clinical collaboration motivation come from? 70% of your score turns on what you do. 30% of your score turns on what everybody else who touches the patient does. So now you have a good reason to think about from whom you take referrals and when, to whom you give referrals and why. What does the money look like? This is data that came out of the claims database we originally modeled the diabetes ECR out of. There was $1.32 billion spent on diabetes care. This is a commercial claims database, pretty rich benefits, national. Big. I'm not allowed to tell you who it is or someone kills me. When you are going to analyze what it would cost as a budget to deliver what our clinical working group said should be delivered to perform that guideline, you would naturally go into the claims data and pull out all the claims that have an ICD-9 diagnosis of diabetes if you want to model a diabetes case rate. And when we did that, certainly not me, the methodologists, they found that there were lots of things that we didn't want to pay for. primary admission for diabetes, diabetic stroke, all the stuff I talked about previously. The red circle is what would have been spent on the vanilla proper care delivery, which would have been $515 million bucks. It means we are spending an extravagant amount of money in this country on potentially avoidable complications. Not never events, that they should never happen, but things that we could really do a lot better job of improving with more coordinated care, seamless care, less fragmented care, engaged patients. So we had an aha moment, and we said, wait a minute, what if we took half the money that we're already spending on these potentially avoidable complications and gave it to the providers in their budgets? That would change the whole transaction. And let me show how it changes. You don't need to read anything on this slide but the two red numbers. Patient 1 is a non-insulin dependent controlled diabetic. Non-insulin dependent controlled diabetic. In our database, that a physician would be paid about $311 a year to take care of that patient. It's a bunch of office visits and some lab studies, not a lot of drugs. When we did what we do to create a case rate, we added $1,000 back because in the claims database, the physicians weren't seeing the patients as much as our doctors said they ought to. We added 10% back because we knew that the fee schedules were all artificially depressed because that's how the payers control their medical loss ratio. And then we put back by the 10 to 50% of the potentially avoidable complications. In our system, the same physician currently being paid $311 would be paid $2,329 for the same non-insulin dependent controlled diabetic, and the system saves half of the $813 million. We were just agog. It was like we spent 6 months arguing over whether this could be budget neutral or not. It's really quite astonishing. We have evidence-informed case rates for all of those conditions. Interestingly enough, they are all of the conditions in the legislation. They are all of the conditions on the national priorities list for what we should be focusing on in this country, and we have case rates. How could you use Prometheus today if you're in an environment where a payer doesn't want to pay in the model that I've described? You can take any claims database and run it through our publicly transparent algorithm that's called the ECR Analytics, and it can tell you what the potentially avoidable complications are in that claims database. When hospitals do this with their own self-employed population, now you have something that physicians and hospitals can actually work on together. When we did hips and knees as a rate, I thought that was a really straightforward thing. What kind of potentially avoidable complications are there with hips and knees? You know, you put it in, you're just kind of over. The most expensive potentially avoidable complication in our database was unexpected bleeds. Now you have something you can work on. What do we do to prevent unexpected bleeds? There are things that you can do. If you're going to be in an ACO-ish thing, the last go-around of the ACO-ish things that were known as PHOs back in 1995, there were food fights over who was going to get the money. The Prometheus system actually, because it says who's rendering what service on the guideline, can tamp down those battles. We think this can help primary care survive, because if payers will front-end money, and we have some pilot sites that are doing this, will front-end money to the primaries to build their own infrastructure, the primaries are taking the bet that they can actually prevent some of the potentially avoidable complications, and they win in terms of the money. The last idea I want to introduce you to is clinical integration. You heard this term probably in 1996. This was in the era where the only kind of IPA that you could have was a messenger model IPA. The messenger model is very weak. It's what I call AOL, you got mail. You get a pile of otherwise competing physicians, they join an IPA, you've had them all over Texas. What can the messenger model do? And there have been settlements that the FTC is engaged in all over Texas. The messenger model is allowed to ask its physicians individually, what are the fees that you will accept to perform what you do? And individually, they send their pile of fee schedule to the IPA, who turns around and says to the payer, AOL, you've got mail, here's the fee schedules that we'll accept. In the obverse, you're not allowed to negotiate the rates. In the obverse, the payer can turn around and say to the IPA, AOL, you've got mail, here's the fee schedule we're offering, how many of your guys want to play? It's incredibly weak, it accomplishes nothing. Financial integration in 1995 was tough. It wasn't available in communities mostly outside of California. The places that took actuarial risk failed. Can anyone here spell Allegheny? And so what's different now? Well, what's different now from 1996 is everyone's getting measured. All of the measurement will be public. The measurement will affect your payment. Scoring well will matter. Here's some truisms I learned from sitting on the board of NCQA for 12 years, chairman of the board for 5. You cannot improve what you do not measure. Clinical integration is a lot about generating data about what you're doing. People will work to get the grade. What gets measured gets done. So be careful what you measure. And I'm telling you, I have clients that say to me over and over again, we're better than the other guys in town. I go, cool. How do we know? Got data? And none of them ever has any data. I have some clients who actually have picked up on this and have begun tracking their own data, so they have data, whether in small groups or across groups, that they can go to payers with and have a reasonable conversation. And the study that came out 2 weeks ago, primary care physicians, to a vast majority, believe that patients in this country are getting more than what they need. I'm shocked. Were you? We all know there's overuse. It's up to the profession to stand up and help prevent this. So what is a better definition of clinical integration, not an antitrust definition? And Jim Reinertson and I wrote this. It is physicians working together systematically, not episodically, not project by project, not because it's Breast Cancer Awareness Month. Physicians working systematically, with or without other organizations and professionals, to improve their collective ability, holding hands together to deliver high quality, safe, and valued care to their patients. We have elucidated 17 attributes of clinically integrated entities, and our basic pitch is it doesn't matter whether you're in your own group, whether you're in the organized medical staff, whether you are forming a network. And I was actually in Houston 3 weeks ago talking to a bunch of independent physicians about potentially forming an independent network. Whatever it is that you're going to be doing going forward, you should be paying attention to these attributes. There's a paper where you can read about 4 different kinds of clinically integrated organizations. And this is something I would suggest you actually deploy, whether in your own practice or in the organized medical staff. It's free. You can find it at that link. And it looks like this. The top bar, which is green, is written around multi-specialty groups or group practices or the hospital-employed physicians. And the row in purple is written for the organized medical staff or a newly coalescing ACO-ish thing. We've laid out 3 scenarios about folks who are, really not doing it at all, just sort of barely getting started around clinically integrating around these attributes, which are things like standing order sets, using guidelines and protocols, highest and best use of nurse practitioners and mid-levels, paying attention to your referral neighborhood, who you take referrals from, what you know about them. But this is something you can actually use to have conversations with your colleagues about what your vision of your own future will look like, given this new environment that is emerging. In conclusion, I would like to leave you with some thoughts that come from Atul Gawande's book, Better, which is a spectacularly wonderful book. If you have not read it, read it, and then read chapters 1 and 5 again. If you have read it, go back and read chapters 1 and 5 again. This book will make you feel wonderful about being a physician and will help you think about the essence of what that is. I think we are at a unique moment in American healthcare history. I think this is a moment for physicians to pull up their socks and understand they have to change their behavior going forward, but they can do it in a way that improves their lives and their patients' lives. So the 3 things that Gawande speaks to as really important for improvement are diligence, the necessity of giving sufficient attention to detail to avoid error and prevail against obstacles. Diligence seems an easy and minor virtue. You just pay attention, right? But it is neither. Diligence is central to performance and fiendishly hard. The second thing he talks about is doing the right thing. Medicine is a fundamentally human profession. It is therefore forever troubled by human failings like avarice, arrogance, insecurity, and misunderstandings. It's really just about people struggling to do the right thing. Ingenuity. You are going to have to bring ingenuity to this new environment. It is thinking anew. Ingenuity is often misunderstood. It is not a matter of superior intelligence, but of character. It demands more than anything a willingness to recognize failure, to not paper over the cracks, and to change. It arises from deliberate, even obsessive reflection on failure and a constant searching for new solutions. Finally, he says, and this is what improving quality and value is about, betterment is a perpetual labor. The world is chaotic, disorganized, and vexing, and medicine has nowhere spread that reality. To complicate matters, we in medicine are also only human ourselves. We are distractible, weak, and given to our own concerns. Yet, still, to live as a doctor is to live so that one's life is bound up in others and in science and in the messy, complicated connection between the two. It is to live a life of responsibility. The question then is not whether one accepts the responsibility just by doing this work one has. The question is, having accepted the responsibility, how one does such work well. That's the challenge in front of you folks going forward. Go get them, and we have a few minutes for questions.
Alice, thanks for an extremely good talk. Ralph Anderson from Fort Worth.
Yes.
In Texas, we have an inordinate number of physicians who practice in either solo practice or very small group practices. You have talked for many years about collaborative relationships between doctors and hospitals. What do you advise the person in the town where there's 25 doctors, mostly practicing in one or one and two groups, working together but not in a legal relationship, as they approach the hospital and try to work out some collaborative relationship?
There are hospitals and then there are hospitals. So there are different techniques for dealing with different kinds of hospital environments. I think the most important thing for physicians who are in onesie-twosie relationships is to start collaborating with each other before they collaborate with the hospital. The hospital is not going to deal with you as any kind of a single entity unless you do something that demonstrates that you have the ability to work collaboratively with each other. And I think that if you read the story of the creation of the Institute for Clinical Systems Improvement in Minneapolis, which was a bunch of independent docs that came together to create clinical practice guidelines that they thought would better the profession. And they drove 2 hours at night in the frozen tundra of Minneapolis to do it. I think that if you folks figure out that it makes sense for you to start talking to each other and working with each other, you can begin to find more of the joy of what you felt in those, when you were young and you would sit around and talk about things that were kind of interesting, but you're going to have to take time to do it. There is no Prince Charming. No one has a solution. You are going to have to develop your own solutions. And it's going to have to come from some vision of what it is that you want to be. It can't be, we just want to be independent. You have to have some better view of what your future is going to be. That's one of the reasons we did the clinical integration self-assessment tool. Sit down with a bunch of your buddies over, your favorite libation and score yourselves on it. Geez, how far are we from really doing something meaningful? What would it take us to get from this scenario to that scenario? I think those are the conversations that physicians need to start having for real in their own communities.
Thank you.
Other questions? Sir.
Just a question. Whenever we are talking about all these quality issues and this, why is it a one-way street? We're talking about the physicians only. Why is never there a talk about a patient responsibility? Like you gave an example of a car, you need to be a responsible driver also. How can we take care?
I will tell you that comment is the first comment that gets made whenever a discussion about payment associated with quality comes up. It's always, what about patient compliance? There are a couple of answers to that question. I'll use the Prometheus design team as an example. I was on the design team, and I spent 4 months making that argument about the following issue. I was somebody who had been told by both my primary care physician and my OBGYN that I should have a colonoscopy for years. I know what it's about. I'm the most sophisticated health consumer you'll ever find. And I didn't do it, and I didn't do it, and I didn't do it. And I said to the design team, these guys have told me to do it. I'm a free-range chicken. I'm making my own decision about the fact that I'm not getting it done. And it's not because I object to it, it's because I don't have time. So I don't have time to do this. And one of the guys, a physician who was on the design team, said, that's wrong. These guys aren't taking responsibility for you. And he was right. If I had been in an integrated setting, somebody would have walked me down the hall to make the appointment to have the colonoscopy. Even in a non-integrated setting, one of the guys could have said, why don't we help you make the appointment before you leave? Let me tell you a story about a clinically integrated environment where people are not matched up together. I did a presentation for the AMA House of Delegates, and we had a panel, and on the panel, Jim Rohack was on the panel. I think I saw him somewhere earlier today. And my own internist, Alan Krim, was on the panel, and I said to him, and I had no idea what he was going to say. I said, tell me a story about what's different about your practice now that you're clinically integrating with people in the community. He said, we thought our colonoscopy rate could be higher. We were at about 66%, and we thought we could get to 75. We thought that the reason was that the patients were scared, or that they'd heard a bad story, or something along those lines. He said, we did a little survey and we found out that wasn't the reason at all. The reason was that they would call and no one called them back, or it was too hard to make an appointment. So he got in touch with the GIs and he said, here's the deal. I'm gonna send you a lot of patients, but here's what you're gonna do for me. You're gonna set up a dedicated phone number that my patients are gonna call, and someone's gonna call them back within 24 hours. These are people who've already decided that they're gonna have the study. Call them. We're gonna have the prep kits in our office that we're gonna give them, and you're gonna give us the path reports from the biopsies that come out of the slides. And their compliance rate went up over 85%, like this. Now there's a different, that's a systems way of handling a patient compliance issue. The socioeconomic aspects of patient compliance, I think, still can be managed. Are they difficult? Of course they're difficult. The biggest problem that physicians have is they don't have time in their practices to engage effectively with these people, nor do they have patient navigators and folks like that. In the Prometheus payment model, that becomes possible. But there's a video that I show of a guy who worked with homeless people, talk about non-compliance, who managed to get their hemoglobin A1C rates down by 2 points. 2 points in a homeless population. Can it be done? It can. You just need to find the time to be able to do it. So I don't have a really simple answer for the health illiteracy issues and the socioeconomic problems that go along with that, but I don't think patient compliance is really the problem with what's going on. I think non-systems solutions are really the problem with what's going on. It's an ingenuity challenge, frankly. One more, and then I think we're supposed to go to a break.
I'm a member of a very successful IPA, but it is a messenger model IPA. So saying that this is weak, and we've had some recent battles with that and done some other things where part of the group got undermined and undermined the rest of the group and that type of thing as well. So I guess the question is, where do we go from here? You've got to identify as a weak. I was looking at the slide. What's step number 2? What can we do? And I'm not sure if I was clear on what you were saying about integrating and that type of thing.
I think what you want to do is look at that clinical integration self-assessment tool. We didn't put IPAs on it, but look at the lower level that's really oriented around the hospital-centric thing and the top level and say to yourselves, we're otherwise not related to each other, but what can we do collaboratively where we're all holding hands crossing the street to standardize to the science as much as we can? What kind of tools can we generate for ourselves? Do you use standing order sets in your practice? Can you develop standing order sets that everybody of like specialties can use in their practices? That's what clinically integrating is about. And then you measure what you're doing, and if you are measuring what you are doing, and you came together for a good, quality-driven reason, then you can say to the payers, we won't take less than this, and it's not naked price fixing. Because the issue, that's the antitrust aspect of how you take an IPA and convert it. So with that, I think it's break time, yes?
Yes, it is. Thank you.
I'll stick around
Ms.
for a few minutes
Gosfield.
outside.